think that you can decide if you would like to look at this or not.
Dr. Marco, go ahead.
Okay, thank you so much. This is a clinical case that summarize many of the features we have discussed so far, and I think it's a clinical case that could be of interest because, as you will see, there is it is a very current topic. So this is a 55-year-old female that had an acute episode of TTP in 1988, together with a bacterial pneumonia that was treated at that time with PEGs and steroids, and she underwent complete remission. The subsequent follow-up was unremarkable, till March 2020, when the patient developed a mild flu-like symptoms that spontaneously resolved. After 1 month, she was admitted to the hospital for interstitial pneumonia. The nasal swabs for SARS-CoV-2 that were repeated many times were all negative, but she had a positive IgG anti-SARS-CoV-2. So she was treated with antibiotics, with hydroxychloroquine at that time, with low-dose steroids, and she was put on antithrombotic prophylaxis. But at some point, the clinical features changed very rapidly, very quickly. The platelet count dropped to 14,000, the hemoglobin dropped to 7.4, the LDH increased a lot, and schistocytes were present at the peripheral smear. So treatment with fresh frozen plasma was started, not PEGs, you have to notice. And other than that, the patient presented also a worsening of her clinical conditions. So she developed neurological symptoms, agitation, and at the end she became unconsciousness. She developed a respiratory failure and a sort of multi-organ failure with a lactate level of 15. So that she was transferred for this hospital to our intensive care unit. The lab test at admission showed a very complex picture. She had an intravascular hemolytic anemia. The hemoglobin was 7.4 with very high level of LDH, undetectable haptoglobin, schistocyte in the peripheral smears. So that, considering the history, we dosed the Adams 13 that was less than 3%, and the anti-Adams 13 were high. She had a very severe inflammation with elevated inflammation marker like C-reactive protein, procalcitonin, interleukin-6, ferritin. The neutrophils were very high, and the C4 was consumed. She also showed a disseminated intravascular coagulopathy with prolonged PT and PTT, low fibrinogen, and high D-dimer. And she developed a multi-organ failure with failure of the kidney, with liver failure, and also heart failure. So the patient presented with an acute TTP together with a severe inflammation, together with a disseminated intravascular coagulopathy and a multi-organ failure. So we started promptly a specific therapy for TTP. We decided to use, considering the very severe presentation at onset, to use methylprednisolone IV for the first days. We started plasma exchange, exchanging more than 1 plasma volume every day, and we started Kaplacizumab. The response to therapy was very quick. The platelet count increased to 46,000 just after 6 hours after the Kaplacizumab infusion. And on day 3, after Kaplacizumab start, the platelet achieved a count of 100,000. But we should notice that they plateaued at this point for 1 week. In contrast with the evidence from the phase 2 and 3 studies that showed us how the median time to reach the platelet response, so that a platelet count higher than 150,000 was around 5 days. Unfortunately, despite this better presentation of the lab picture, the clinical picture was not well enough. The patient was still unconscious, so that we performed a brain CT scan that showed petechial hemorrhages, but together with some two wide ischemic lesions. So that considering that despite these two large ischemic lesions, considering that the low platelet count, considering the presence of the cerebral petechia, considering that the patient was on Kaplacizumab, we decided not to introduce no antiplatelet therapy and nor the antithrombotic prophylaxis. A CT scan repeated after 48 hours showed the stability of the hemorrhagic petechias, so we were concerned about the two ischemic lesions. So at this point, we decided to start also the antiplatelet drug with aspirin 100 milligrams. And on day 9, the brain CT scan showed a complete resolution of the hemorrhagic petechia. And considering that the patient was still unconscious and with persistent immobilization, we decided to add also an antithrombotic prophylaxis. Unfortunately, on day 12, so 3 days after the introduction of antithrombotic prophylaxis, the patients showed hemolysis that led to a reduction in the hemoglobin. We transfused the patient and we performed an urgent CT scan of the chest that showed an active bleeding from an artery in the main right bronchus. So that the patient, this was an emergency bleeding that should be treated in emergency context, and we stopped immediately the Kaplacizumab, the aspirin, and the low molecular weight heparin, and we had to treat the patient with a concentrate of von Willebrand factor and factor 8 to revert the action of Kaplacizumab. And the patient underwent an emergency arterial embolization transcatheter. On day 12, so the patient was on plasma exchange and steroids and Kaplacizumab that then we stopped. She achieved a platelet count of more than 150,000, and that was stable at this point. The Adams 13 level was 58%, and the anti-Adams 13 antibodies were undetectable. So that we decided not to restart Kaplacizumab, and we continued just the PEX for 2 more days. So this clinical picture represents an atypical presentation of acute acquired TTP, which was relapsing during an infection by SARS-CoV-2. And we speculate that this SARS-CoV-2 infection that was responsible for this severe systemic inflammation could have led to a diffuse activation of the microvascular endothelium that could have led to the TTP onset. At the same point, the TTP that onset in this situation with low Adams 13 led to a more deep endothelial activation and therefore a coagulation activation that led to the overt disseminated intravascular coagulation that in turn contributed to the multi-organ ischemia and multi-organ failure. We also speculate that the diffuse involvement of the microvascular wall by both TTP and both the SARS-CoV-2 infection could also have led to the bleeding, to the highest bleeding tendency, of course, considering that the patient was together on Kaplacizumab together with aspirin and low molecular weight heparin. And we also speculate at last that the sluggish platelet count normalization over 150,000, which happened only after 12 days of treatment, could have been a consequence of the severe inflammation. And if you want to read something more about this paper, we have published this in Hematologica last year. And I would like to, this is the group I work with in Milan with Professor Ferrari and all the other colleagues. And of course, I couldn't have time to discuss many other topics, such as how we manage patients during pregnancy, with TTP during pregnancy, or patients that with TTP remission phase that could undergo surgery or an infection, but maybe we have time to discuss that during the question and answer session. Thank you, everybody, for your attention.
Thank you, Dr. Marco, for that lovely lecture, followed by a beautiful case discussion. extremely educative. We'll give you a break for 5 minutes before we take up the Q&A session, and we will just solve the puzzle that was asked to the students. So I'll just share my screen. Okay, so before we take up the questions for Dr. Marco, we will just give you the answer to the quiz that was put up to you. This quiz was related to GATA2 deficiency, and you were given 9 statements and you were asked to pick up the false statement. And these were those 9 statements. GATA2 is a zinc finger transcription factor. Is a correct statement. It is required for the maintenance and proliferation of hematopoietic progenitor cell is also correct. So first statement is correct. This is a single genetic defect. That is a correct statement, but it has an extremely varied hematological spectrum as far as clinical presentation is concerned. So this statement is also correct. The Monomach syndrome, that is deficiency of monocytes and various infections. One of the most important of this is Mycobacterium avium complex. So Monomach syndrome, as it is called, is a correct statement. Amberger syndrome is shows you the importance of GATA2 in formation of lymphatics. So when there is GATA2 deficiency, there is deficiency of lymphatics leading to primary lymphedema. And then the associated hematological entity of myelodysplastic syndrome. The commonest of the hematological problem associated with GATA2 is myelodysplastic syndrome. So this is a correct statement. Patients of GATA2 deficiency or mutation are associated with immunodeficiency. And this immunodeficiency is characterized by deficiency of dendritic cell, deficiency of monocyte, as was mentioned here, and the deficiency of these 2 groups of lymphocytes, the B lymphocytes and the NK cells. So DCML deficiency is also a correct statement. The wrong statement comes here, that these patients very, very, very unusually will have acute lymphoblastic leukemia. When they have acute leukemia, or if the MDS evolves into a leukemia, it is acute myeloblastic leukemia. So the 6th statement was the wrong statement. There are patients of GATA2 deficiency who can present as just chronic neutropenia, not only in young children, but also up to adults and young adults. So that has to be kept in mind in the workup of patients who have chronic neutropenia. Similarly, young patients with aplastic anemia may have underlying GATA2 deficiency, and of course, all inherited marrow failure syndromes. One of the important type is GATA2 deficiency. So these are all correct statements. So you can see varied hematological presentation and importance of it in immunodeficiency and importance in lymphedema happening. And the wrong statement being number 6. So familial ALL was the false statement. Those who answered 6 are the correct ones. This is a beautiful cartoon showing you the whole clinical spectra of GATA2 deficiency. So you see monocytopenia, predisposition to MDS. Monocytopenia leading to various kinds of infections, including papillomavirus, mycobacterial, Monomach syndrome. Here you see the Amberger syndrome, which is characterized by lymphedema. They may also have sensorineural deafness, and there may be physical stigmata of hypotelorism. One of the characteristic cytogenetic abnormality in these patients with hematological malignancies, monosomy 7. Familial occurrence of MDS and AML is there, and then the immunodeficiency due to loss of B lymphocyte, natural killer lymphocytes, and the dendritic cells, what is called DCML. So this cartoon gives you all the complete picture of GATA2 deficiency. And these are a couple of pictures from the literature of lymphedema in patients of GATA2 deficiency. So those who answered 6 are the winners. And we had a lot of attempts, but these were the one who sent the correct answer. Dr. Anjali Patel, Dr. Giri Punja, Dr. Neeru Singhal, Dr. Muralidharan C, Dr. Virti Shah, and Dr. Leo Prince method. But unfortunately, you were not the fastest. And the fastest is the winner who was winner last time. And Ramesh, congratulations to you. You are correct and you are fastest. And as he was introduced last time to you, he's doing his DNB in Department of Hematology at Sir Gangaram Hospital, New Delhi. So once again, Dr. Ramesh B is the winner today. Well, thank you so much. I'll stop sharing. And now we'll go to the discussion with Dr. Marco. So all of you who are here, discussants, please, you can open your videos. We will have a very interactive session. And we begin with Dr. Jasmita Das.
Good morning, sir. Excellent lecture, Dr. Marco. So for the first question that I have is that usually to monitor the acquired TTP patients, we use the ADAMTS13 assay 3 months after they are in remission. So do you see the role of a simpler assay or a more widely available assay like a D-dimer to monitor them? Also, the second part to this question is that I recently read some papers about an open confirmation of ADAMTS13 heralding relapse before the levels actually went down. So do you see any value of this assay or this assay moving into the routine diagnostic testing anytime soon?
I thank you for this question. It is a very important question because, as you well know, TTP is an acute disease that we have to treat very fast. And to confirm the diagnosis, we need ADAMTS13. So the possibility to have a more a test that can be done in an urgent situation is very important. And unfortunately, also in our center, we still use a homemade test that takes time to be performed. And we are lucky because we have some technicians that are dedicated to do this test, so we can call them also at night during the weekend, so we can do the test at each time. But as you can imagine, this cannot be performed in any center. That's why there is this network of referral center, and other centers send us the patients and send us the plasma samples. So for sure, to have a quicker test would be amazing. And there is one that we have our group has validated, in our lab group has validated, and it is an automated test that will give us the result in a very quick time, in less than 1 hour. So this will give us the possibility to do the diagnosis quickly and also more widely spread in the territory, not only in the referral center. And coming to the second question, could you please ask again the second part of the question?
So the second part of the question was regarding the open configuration of ADAMTS13, which in recent papers they said would happen before the ADAMTS13 activity actually dropped. So for monitoring patients, do you have any experience with this assay, or do you see any value that this assay might add?
No, we don't use this assay, and so I don't have data to add on this. I think that my lab colleagues would be better than me to answer this kind of question. So maybe it could be a topic of another lecture.
Thank you, Dr. Jasmita. We'll take one question from the audience. Dr. Kannan wants to know about the interpretation of ADAMTS level around 20 to 25%. And he also wants to know how is the reliability of the assay, reproducibility and reliability.
Yeah. So the test is highly reliable and highly reproducible because it has been standardized. Even if we have many different kind of tests, and there is a difference if you use different kind of tests, there is a slight difference. But the most important thing is that the threshold of 10% is always reliable between the different tests. And how to consider in the clinical setting these particular levels of ADAMTS13. We depends on which kind of patient patient we are facing, because the clinical presentation is always to be taken in mind. If we have a patient with the classical acute presentation of a TMA, of a thrombotic microangiopathy, and we have a level of ADAMTS 13 that is not less than 10%, we can exclude a TTP, and we should consider another kind of thrombotic microangiopathy. We have said that in the range of value of ADAMTS 13 between 10 and 40%, this is a gray zone in which all the other TMAs can have a presentation. But to have a diagnosis of TTP, you need to have a level of ADAMTS 13 less than 10%. It is different, the situation of the chronic patients in the remission phase, but in this kind of patients, most of the time we have already a diagnosis, and we should also remember that it happens sometimes that we see patients as a second opinion that have had in their life some doubt of having had an acute TTP. They have been treated not with the gold standard treatment, so it's really difficult after 10 or 20 years to say if the patient has had a real acute TTP or not. So in this particular kind of patients, having a level ADAMTS 13 around 30% would be really difficult to manage, because after the acute phase we cannot make a definite diagnosis. So the approach that we have in this kind of patients is just to monitor them and to consider if there is a familiarity for the disease, because we can miss otherwise the congenital cases. And in this, if we have this suspect, we can consider the gene sequencing for have a definitive diagnosis.
Thank you, Dr. Marco. We'll move to our second discussion, Dr. Vipin Kulkarni. He is the center that does the ADAMTS assay and the antibody in Mumbai. So he will discuss with you.
Hello, Dr. Marco. It was indeed a very comprehensive lecture, and thank you very much for that. My questions are also around the diagnosis part. So as we know that ADAMTS 13 activity assay is the method of choice always for the diagnosis. As the antigen may not always correlate very well with the activity, particularly when it is in the mild moderate range. But also on the other hand, the antigen correlates very well with the prognosis, disease prognosis, the mortality. Also, there are many labs which do not have the specialized equipments for the FETS assay and the activity assay. So my question is whether would you suggest performing the antigen assay along with the anti-ADAMTS 13 antibody, which may correlate fairly well in the disease situation?
So if I heard well, because I can hear not very well, you are asking if we suggest to consider also the antibody test together with the antigen test?
Yes, yes. So in settings where the activity assay is not possible.
Yeah, okay. Yes, we always perform this test, but I think that we should discriminate what we should do in the real acute phase, so in the first 24 hours, and what we can do later. So in the first 24 hours, I think that we have to we should start as a clinician. I will start if I have a high suspicion of a TTP, even if I don't still have the ADAMTS 13 result. I will start immediately the PECs in this kind of patient, and I'm also allowed now to start immediately the first dose of Kaplacizumab. But then I need to have the result of the ADAMTS 13 level in the subsequent 24 hours, because otherwise I'm not allowed to go ahead with Kaplacizumab, for example. So I think it's very important in the first 24-48 hours to have a result of the ADAMTS 13 level. So this test should be performed in this time lapse.
So even if it is the antigen assay along with the antibody, if you don't have the...
Yes, exactly. Then we should, of course, collect the basal plasma, because sometimes we forget this, but we need to be aware that we have to collect a normal, an important amount of plasma that will allow us to do all the tests that we will need to do. And in the next days, we will do the test for the antibodies. And this is important. This is very important to follow the patient in the subsequent days and months, because having the basal levels of the antibodies gives us an idea of how the disease has went further, and how I should go ahead with immunosuppression. Because when you start PECs, of course, after PECs, you will not have any more an idea of which is the degree of the immune system activation. So to conclude, we recommend to perform the antigenic test in the first 24 hours, and then we have time to do the antibody test.
Thank you.
Thank you, Bipin. A question from audience. We have Dr. Afaq Ahmed Khan from Srinagar. He wants to know about what are your criteria for giving platelet transfusion? Any particular level of platelet count, or if the patient is bleeding, will you give platelet transfusion?
Okay, so it is very important to take in mind that the pathophysiology of the disease. So the pathophysiology of the disease is represented by the clot formation, which are rich in platelets in the small vessels, so that we should avoid, whenever possible, the platelet transfusion. Even if, as I said in the presentation, we have to place a central venous catheter, which is associated with potential bleeding, and also with 10,000 platelets, we should avoid to do platelet transfusion. So we have also to consider, this is just to highlight the fact that don't transfuse platelet in a patient with acute TTP in the first days. We have also to say that this kind of patients usually have a presentation with not very life-threatening bleeding. They usually present with mucocutaneous bleeding that, even if they present with big hematomas, they usually don't represent a life-threatening event. So we don't really need, in this kind of patients, to block bleeding in the acute phase. We are more concerned about the ischemia, which is caused by the formation of thrombi in the microvessels.
Thank you, Dr. Marco. Dr. Tushar, your question.
Thank you, sir. Hello, Dr. Marco. Thanks for the wonderful presentation. Yeah, Dr. Marco, currently we are using the term TTP for defining TTP, as well as syndromes which have TTP-like presentations. So there is something called as Ttp-Like Syndrome, which phenotypically behaves like TTP only, which has microangiopathic hemolytic anemia and low platelet count. But of course, the pathogenesis is different and the treatment part is different. So actually, I felt that one of the cases you presented in the last part was a bit of TTP-like syndrome because of its typical presentation and involvement of multiple organs. So how well we know about this TTP-like syndrome, and what should we suspect in the peripheral smear and diagnostically to differentiate this as an important entity from the TTP?
Yeah, you're right, of course. And unfortunately, the case was presented because it was a challenging one, and it includes many different topics that we have discussed. And of course, we don't have an answer to what has happened to this patient. We are glad that finally she's well, and she's still well, luckily, but it is still challenging. We are still thinking about what happened to her endothelium, because that was the treatment. Everything started there. So considering the clinical case, we can say that the patient had TTP in this case because she had all the features of TTP. She had the history of TTP. She had it 30 years ago, and she had a low level of ADAMTS 13, which was really undosable, undetectable, less than 3%, which is the sensitivity of our test. And she also had a high titer of antibodies, anti-ADAMTS 13 antibodies. So I think that in this case, one of the only thing that is really clear is that she had TTP. Then we can discuss about the rest. But we had a clear diagnosis of TTP and she responded to therapy. But you are right saying that these diseases are overlapping, and I showed you the first one of the first slides in which we showed that TMAs are a wide range of different diseases, and the diagnosis is challenging because of the overlapping symptoms. The three main characteristics are common to all these diseases. So the hemolytic anemia, the thrombocytopenia, and the ischemia in the different organs are typical of all these diseases. So if it's easy to diagnose TTP, if you suspect it, of course, if you have it in mind, you can make a clear diagnosis just doing the test of the ADAMTS 13. For the other one is much more difficult. And the differential diagnosis, especially for the secondary form, other than the primitive, because for the primitive forms, we have some tools. We have some lab tools that help us to make the diagnosis, the infection, the Shiga toxin, the Escherichia coli enterotoxogen strains, or the defect in the complement cascade. But for the acquired forms, it's really challenging. And I have had a few months ago a case of a thrombotic microangiopathy of a patient with multiple myeloma that was treated with carfilzomib, for example, and the diagnosis of the differential diagnosis was very challenging in that situation. So we have tools easy for TTP, but not that easy for the other forms so far.
Thank you, Dr. Tushar and Dr. Marco. We'll take one more question from the audience. Dr. Udani has asked almost 3 questions in one question. You discussed about steroids, and he wants to know about the duration of steroids. How do you decide? And then he also wants to know about aspirin and low molecular weight heparin. How do you decide indications for them and the duration of treatment of them?
Okay, as regarding to the first question for the steroids, the guidelines are clear on that. We should use prednisone at the dose of 1 milligram per kilo per day, and we should go ahead for 3 weeks. In some cases, we can go ahead to 4 weeks at the full dose, and then you should taper the steroid within a period of 4 to 8 weeks, depending on the severity of presentation at onset. If a patient has a very severe presentation, like the case that we have presented, you can consider to use intravenous administration of steroids, and we use methylprednisolone. The schedule is a methylprednisolone IV, 1 gram for 3 days, and then you can decide to go ahead with prednisone orally or still methylprednisolone IV, but at the dose of 1 milligram per kilo per day, not more 1 gram per day. And as regarding to the other question, we don't use regularly aspirin in TTP. So the case that I presented could be misleading on this. We used aspirin in that patient because you had 2 large ischemic lesions in her brain. That was not a direct consequence of TTP, because TTP doesn't give this kind of presentation. TTP is responsible for ischemia of the small vessels, not large ischemic lesions in the brain. So that's why we used aspirin. But in TTP patients, you don't need to use aspirin in normal condition. And as regarding to the antithromotic prophylaxis with heparin, you should consider that very carefully in this kind of patients, because in the pre-Kaplacizumab era, the rate of thrombotic events were higher, and I'm not talking about the events, the thrombotic events in the small vessels, but I'm talking about thrombotic events in the big vessels. And especially we find thrombosis in the vein in which we have placed the central venous catheter. The thrombosis of the catheter is quite normal. We see it in the large majority of patients. So in the pre-Kaplacizumab era, we started the antithrombotic prophylaxis in these patients, but now we should be aware that Kaplacizumab is associated with an increased risk of bleeding. So we have to balance well the decision to introduce antithrombotic prophylaxis in this patient or not.
Thank you, Dr. Marco. Dr. Abhishek, your question.
Good afternoon, sir. So my first question is, as we know that the assays are now very sensitive to detect ADAMTS activity. So those who are having less than 10%, say around 5%, 2%, can we predict relapse in these cases based on the activity level of these cases?
Okay. Unfortunately, as you said, below this the level of 10%, we are not aware of the prediction potential of this test. So we can consider the threshold above or under the 10% level. So I have to say that from a clinical point of view, because I'm a clinician, as you know, so I'm more expert on that part than on the fine things of the lab issues. But we consider also the patient that in the remission phase still have low levels of ADAMTS13, and some of them, we have many of them, of these patients that have levels of ADAMTS13 around 20-30%. Nowadays, we consider the threshold. The threshold of 10% is to define is really associated with a really high risk of relapse. So we should decide in this patient to treat as soon as possible a preemptive treatment, and that's what we do in our center. But we have many data, much more evidence that also with patients that have a level of ADAMTS13 around 20-30%, the risk of relapse is high. And the last guidelines that have been proposed a few months ago also suggest us to consider the preemptive treatment also in patients that have levels of ADAMTS13 lower than 20%. So we are moving toward changing this threshold, at least for patients in the remission phase.
Thank you, sir. So one more question. As there are some areas, resource-limited areas, not so well-connected areas, where Kaplacizumab may not be available. Mostly, it is not available. So in these areas, so is it okay to go ahead with Plasmic Score only, or in these areas where we do not have assays also available, should we go ahead with Plasmic Score, or we should have these assays developed in these areas also?
Yeah, for sure. Luckily, we have these two scores. We have the Plasmic Score and the French score as well, as you know, and I didn't present it because of time questions, but they are very useful tools to predict the fact that a patient, based on some lab parameters and clinical features, we can predict a patient to have a level of ADAMTS13 less than 10%. And these scores work quite well. So if we don't have the possibility to have the test, to perform the test, of course, we should use these tools to help us decide if starting a treatment or not. And we should also consider that these patients usually respond quickly to the treatment if it is well done. So plasma exchange together with steroids. So also the clinical outcome will help us in deciding later on if it was really a diagnosis of TTP or not, if we don't have the test available. And coming to Kaplacizumab, of course, we are aware that is not available in all over the world, but also in Italy, we not all the centers, every center can use it, of course, but there is no not all the center are have an expert that can measure this drug. So this drug is really used even in Italy only in some referral center. There are many all around our country, but not all of them use it still.
Thank you, sir.
Thank you, Abhishek and Dr. Marco. One question from the audience. Dr. Khaitari wants to know, can you suspect relapse of TTP only if the platelet count drops and there is no actual hemolysis?
Yes, it's a very good question, because sometimes we face also this situation. And I can say that usually this presentation represent a very early phase of the disease. But we should consider that if we don't recognize promptly this situation, the platelet count will drop very fast. And so if we see a platelet drop in a patient that has a history, of course, of TTP, that is isolated, we should start immediately a treatment also in these patients, because the microangiopathic hemolytic anemia will start soon after.
Thank you, Dr. Marco. Dr. Amrita, your question. No, we still can't hear you, Dr. Amrita. No, we still can't hear you. No, you try to work that out. I'll take a question from the audience meanwhile. So what you could not cover has come up in the question. Management of TTP in pregnancy. Dr. Sui Keat wants to know.
Okay, so we should consider two different scenarios, of course. The first scenario is having a TTP in pregnancy, and we do know that pregnancy is one of the triggers of TTP. And we can have during pregnancies an acquired TTP, but we can also have the onset of a congenital TTP that has never come out during the lifetime of the patient. So the acute treatment, the treatment of the acute phase is exactly the same of the other patients out of pregnancy. Of course, in pregnancy, we will also have to face with the fetal outcome and not only with the patient outcome. The different situation is a patient that has already a diagnosis of TTP, congenital or acquired, and this patient comes to our clinic to discuss about the possibility to have a pregnancy. This is a challenging situation that we have to face because in the past, many hematologists were used to say to this patient that they couldn't have a pregnancy, but nowadays this is not the correct approach, also according to guidelines. So we should discuss very well the situation with the patient. We should tell them, the patient, that the pregnancy will be at risk, of course, for her and for the child. But we also have to say that it's possible to undergo a pregnancy. We have to reassure the patient on that. And we should tell the patient that she will be very strictly followed up by the hematologist. So which is the approach that we follow with the patient. We say them that they need to schedule the pregnancy. They cannot just come out to our clinic and say, I'm pregnant. We want to plan it, because we want to do that in a situation in which the ADAMTS13 levels are high enough to start in a best way possible. After that, when the patient is pregnant, she needs to come to the clinic at least once a month in the first months to dose the ADAMTS13. levels. Because if we see a drop in the ADAMTS 13 levels, we can do a preventive treatment if necessary, and we can manage well the situation. The current guidelines, the STH guidelines, say to use the prophylaxis always in these patients. This is a weak recommendation based on low levels of evidence, but they say that we should do PECs in patients with acquired TTP once a month, and we have to infuse plasma, fresh frozen plasma, in patients with congenital TTP once every 2 weeks, depending on the levels, of course, of the ADAMTS 13. Our approach is quite different because we don't use this preemptive treatment in all the patients, but we prefer to follow up the patient every month with the ADAMTS 13 dosage. And in the last 3 months, we, depending on the levels of the ADAMTS 13 that we have had in the first months, we decided to shorten this interval of dosage of the ADAMTS 13. So this is we use a wait and see approach, but we want the patient to start the pregnancy in a situation that is considered safe.
Thank you. There's a live question from Dr. Chandrakala. If it's a congenital TTP, then after the delivery, what kind of prophylactic treatment do you continue?
What kind of, sorry?
Prophylaxis.
Okay.
Congenital TTP, pregnancy, delivery has taken place. After that, what do you do?
Okay. So it depends on what, after delivery, it depends on what the patient was on prophylaxis before the pregnancy, because the situation, other than the six weeks after delivery, which is the puerperium, in which the hormonal situation is still unbalanced as during the pregnancy, and even worse, we should continue with prophylaxis in this period for sure, and then we will go back to the scheme of prophylaxis, the schedule of prophylaxis that the patient were used to do before the pregnancy. So after, I will consider just the 2 months after delivery at a higher risk, and then the risk will go back to the basal one.
Thank you. One more question from the audience is related to cystocytes. Do you ever make a diagnosis of TTP in the absence of cystocytes?
No, because schistocytes are a hallmark of TTP, because it's just these fragments of red blood cells coming through the platelet clots. But we should be aware of how is reading the peripheral blood smear, because if it is a hematologist, I would not have any doubt about the fact that he has seen or not schistocytes. If we are in a hospital in which, and unfortunately it happens, and I have managed some situations like that from peripheral smears from hospitals, from different hospitals in which the schistocytes were not present, and they were reviewed by our hematologist, and in fact they were there. So TTP is always with the schistocytes. Of course, you should consider also that if you are taking a blood sample from a patient that is in the very early phase, as you mentioned before, with just the platelet count drop down, you may not see already the hemolytic anemia. So no schistocytes in this situation.
Thank you. Dr. Amrita Saraf, let us see your audio now.
Yeah, so sorry for the confusion. And thank you. It was really a nice presentation. And I have a couple of questions to Dr. Marco. So one is like, as we all know that COVID-19 is affecting all of us badly, and there have been a lot of discussions on this. So my question is like, are these patients of immune-mediated TMA on rituximab, are they at higher risk of COVID-19 infection or vice versa? So what is your comment, Dr. Marco?
Yeah, you're talking about patients on rituximab, right?
Yes.
Okay. So we have, of course, this. We were in trouble with this issue as well, because many of our patients had performed rituximab, but we tried to have a discussion with the oncohematologists that use rituximab much more than us at higher dose, not higher doses, but with much many doses than the 4 that we just use in our setting, and they use, of course, together with chemotherapy, which is much more immunosuppressant than the schedule that we use. So even though we were concerned at first, the data showed us that there is not a real increase in the rate of infection in this kind of patients. Of course, we should be aware that these are immune suppressed patients because they also do steroids. So we should really be careful in deciding to use that in any case. But I think that for us, the more challenging issue was if using rituximab as preemptive treatment in patients that were in the remission phase during the last 2 years after COVID spread out, and for which we, in another situation, we would have decided with no doubts to start rituximab. At first, we decided to delay the start of rituximab as preemptive in these patients, but after seeing the outcomes and some evidence from the literature in other situations, we decided to start it and not to risk the possibility of an acute TTP episode in these patients. So we are going ahead with treating also preemptively our patients in chronic phase.
Okay, great. Thank you. So I have one more query. So what is your comment on the role of testing complement protein antibody to these complement proteins and gene mutation in reference to TTP? Is there any role of doing all this?
What do you mean exactly?
Like in this TTP, is there any role of testing complement proteins in the diagnosis and monitoring?
Okay. Sorry, I didn't get the question before. Okay, so testing the complement doesn't have any utility in TTP diagnosis, because I think that when you have the suspicion of thrombotic microangiopathy, the first thing that you have to do is rule out TTP. Right. So it's easier, of course, if you have available the test, it's easier just to do the Adams 13 dosage. If you exclude the presence of TTP, now it's more challenging because you have to decide which other kind of TMA you are facing with, and we don't manage this kind of patients actually. I mean, we just manage TTP in our center. We have another colleague that we are involved in the differential diagnosis, of course. But when the diagnosis of TTP is excluded in our center, the patient is followed by another team that is expert in HUS, atypical HUS, or all the other kind of thrombotic microangiopathies. So in that case, we have a panel of antibodies and genes that we perform to do the differential diagnosis. And if unluckily we are also not able to define a primitive thrombotic microangiopathy, we have to face the situation of a secondary TMA, which is really challenging because we really have no idea how to manage it and how to diagnose it because we don't have specific tests. Of course, it's just a clinical and exclusion diagnosis.
Okay, thank you.
Thank you, Dr. Amrita and Dr. Marco. So one more question from the audience. Dr. Lim Su wants to know, what is the place of vincristine in the management of refractory TTP?
Okay, for sure, vincristine together with cyclophosphamide and also splenectomy, it was just a line in my slides, were used in the past in patients that were refractory to the first-line treatment or patients with exacerbations. But nowadays, I can say that I think there is no role for these drugs, at least in the normal management. We still have patients that doesn't respond even to rituximab, that don't respond to cyclosporine, to steroids in different line of therapies. And in these patients that are, I have to say, really anecdotal examples, we should consider still nowadays these immunosuppressants. I remember a patient that we have managed 2 years ago. He was a patient with a monoclonal gammopathy, not an overt multiple myeloma, but just a monoclonal gammopathy. And in that situation, we couldn't achieve a response even with the cyclophosphamide that we used in that case at low dosage, of course, not the dosage that we use in oncohematology, but we didn't get any response even with cyclophosphamide, and it was the only case in which we use bortezomib, which has been associated with this with the response in some reports in the literature. But these are really sporadic cases in which we really don't know what to do, and we consider to use everything that we have available.
Thank you. The question from Dr. Ganesh about the levels of ADAMTS13 antigen by which you diagnose congenital TTP. Are there cutoffs? What level you diagnose congenital TTP?
Yeah, the cutoff is the same, is less than 10%, okay? But if you have, this is for the acute, phase, of course, usually it depends, of course, it depends on which kind of mutation you have on the ADAMTS13 gene, because different kind of mutations are associated with different levels of expression of the protein. And we can find patients that have amounts of ADAMTS13 which are around 20–30%. And in this situation that are more challenging, of course, than the others, we have to consider the family history. We have to ask the patient if she has had, if she's a female, she has had or not already a pregnancy, because if I have a patient with, for example, 30% of ADAMTS13 that has had 2 pregnancies and she didn't develop any acute episode of TTP, I think that I likely can rule out congenital TTP, because the pregnancy is a very strong trigger of the acute phase. If other than the clinical history and the familial history I cannot decide, we should, and if there is, we feel that there is the necessity from a clinical point of view, we should undergo the gene sequencing to see if there is the mutation or not.
Thank you. Dr. Ganesh has a question. In a case of relapsing TTP, will you recommend rituximab maintenance?
Okay, rituximab maintenance is not used in this situation, but if a patient has a relapse, I would consider I would manage for sure the acute phase of the relapse, and after that we will decide if doing also the rituximab course of treatment, depending on the ADAMTS13 level that I achieve at the end of the treatment of the acute phase. If I achieve a normal level of ADAMTS13, for example, I achieve 60, 70, 80%, which is normal, I would not do anything at that moment. I would not treat the patient with rituximab because we don't need it. The patient is in remission at this point, but we will follow the patient in the next months very closely, and I will use the preemptive management when I see all the antibody titers comes up or the levels of ADAMTS13 going down. Yes, I think this is the approach that we use. So don't use rituximab just as front line if a patient has a relapse. Just treat it with the normal acute phase treatment, then you decide if you need rituximab or not. You should decide to use rituximab, for example, if a patient has had many acute phases in the last months, and but still based on the levels of the ADAMTS13. Because if you have reached a normal level of ADAMTS13 with no antibodies detectable, you don't need to use rituximab. We will not add anything.
The question related to percentage of cure in patient of acquired TTP. Are there patients who get cured?
Who get, sorry?
What percentage of patients of acquired TTP are cured?
Okay, sorry. Okay. It depends on what we mean for cured, because unfortunately acquired TTP is an acquired autoimmune disease. So by definition, we cannot be really aware of the fact that the patient is cured until he relapses. We have seen the patient that I presented the clinical case that he had the relapse after 30 years. So that maybe this patient has some predisposition factors that predispose them to have a new acute phase of TTP when there is a specific trigger. And so far, unfortunately, we don't know. We don't have any awareness of which are these factors. So we cannot predict if a patient is cured or not till he will relapse.
Thank you. Dr. Deepak has a question. If you had a stormy course during first pregnancy, do you do any specific management during next pregnancy?
So if you have during the first pregnancy, what?
Very difficult case during first pregnancy to manage because of a very maybe marked exacerbations of TTPs, very stormy course, difficulty in managing. Then during second pregnancy, do you do anything specific?
Yeah. Okay. So if the patient has had the pregnancy and a previous pregnancy with an acute TTP, I will not do the PECs as preemptive treatment, but I will monitor the patient more closely, because we are always, all these patients are exposed to many triggers during their life, and we have seen many of them that have had only one episode of TTP. And they have exposed to many triggers in the subsequent years. For example, I'm talking about surgery, I'm talking about bad infections, and they don't relapse. So we are not able to predict if the patient will relapse again or not during the second pregnancies in this specific case. So to expose the patient to a potentially harmful treatment, which is PECs in this case, we think that is not necessary, and it's better to really very closely monitor the patient. For this patient, I would monitor maybe every 2 weeks, at least at first, to see how Adams 13 will act during the pregnancy.
The question is related to congenital TTP. Will you give them intermittent prophylactic factor 8 from Grifols?
Okay, so I showed that particular aspect because nowadays we still don't have available in the clinical practice a replacement therapy for Adams 13. So the recombinant Adams 13 is not available so far, but is in its third phase clinical trial currently. So we hope that we'll have it soon, especially for the congenital patients, of course. So for this patient, I will consider if they have had or not a acute phase TTP, and depending on the severity of the acute TTP, we will decide how to manage in the long term, because exposing the patient to an infusion of fresh frozen plasma, of course, is challenging, because it's harmful, could be harmful because they can develop after many doses of, I'm talking about fresh frozen plasma now, you could develop allergic reactions after many infusions, and they need to go to the hospital every 2, 3, 4 weeks to do that. So for young patients, it's a very important issue that affect their lifestyle. Considering these products that have amount of Adams 13, we have to consider that it's true that CoA8 and also alpha-8, even if at less extent, they contain Adams 13. They are the products that contains the highest level of Adams 13, but it's still very low. We have in the CoA8, we have 9 units of Adams 13 per 100 units of factor 8. So remember that you are giving to the patient not only Adams 13, but also factor 8 in a patient that is prothrombotic. So I think that I would not use it, and we don't use these concentrates in these patients because we are scared about the content of factor VIII in these products, and I would continue to go ahead with fresh frozen plasma in very selected patients because of the thing we have said, waiting for the recombinant Adams 13 to be available.
Thank you. Dr. Ganesh wants to know, is there any gene therapy for congenital TTP?
The answer is very quick, not so far.
Yeah. There is a case shown by Dr. Alka of congenital TTP with twin pregnancy. And again, there was an acute exacerbation needing treatment of TTP, but one of the fetus died. Now, she wants to know what to do with the other fetus, to terminate the other fetus or continue with PLAX therapy.
I think that this is a very challenging situation. We have to discuss very deeply the situation with the patient, because I think that the last decision is for the patient. Not we don't have to take this decision. We have to make aware the patient about the risk for her, because if you have already had an abortion, the risk for the mother is even higher than in other situation. And what we do in our center, luckily we haven't faced a situation like that so far. We have had patients that have lost their only fetus, but with a situation like that, I've never had a situation like that. But we usually discuss this not only with the patient, but also with our gynecologist, because we have a group of work together with the gynecologist, for example, for this to manage this situation. But TTP patients, because it is a really rare disease, we have a specialist for each specialty in our hospital that is the referral one to discuss with the cases in very specific ones like this. So I don't have an answer to this question. I think it's better to discuss very in detail with the other specialist and with the patient.
Thank you. Dr. Ming Lo wants to know about SLE with TTP. Does the treatment differ? SLE with TTP. Systemic lupus.
Okay, sorry. Yeah, TTP is an autoimmune disease. We are talking about the acquired form, of course, and we find very often an association with other autoimmune disease. Lupus is one of that, of course. We can find isolated lupus anticoagulant antibodies in some cases, but in really few ones we also find an overt lupus, systemic lupus erythematosus syndrome, but we find also other kind of autoimmune diseases. In fact, these are among the comorbidities, among the associated diseases that have been described with TTP. These are the most common. So these patients, as before, are followed together with our immunologists that luckily for us are on the first floor while we are on the second one in the same building. So we have a daily exchange of opinions on these patients.
Right. Dr. Radhika wants to know, at what frequency do you monitor ADAMTS levels?
Okay, so after talking about the acquired form, of course, after the acute episode, in the acute phase, we control the Adams 13 after we have reached the normal levels every week till the patient is doing the therapy. When we decide to stop the therapy, I'm talking about the steroids, the patient starts his follow-up. The follow-up in our center is the first one at 1 month after the stop of the therapy. And then, depending on the results, if the patient has achieved a normal levels of ADAMS 13, we control the patient every 3 months for the first year. For the first and a half year, depending on the severity of presentation at onset. Of course, this is arbitrary. This is not suggested by any guidelines. After the first, if the patient remain in a good remission with normal ADAMS 13 levels without antibodies, after the first and a half year, we start to prolong the time between the visits, and we pass from every 3 months to every 6 months for a couple of years, and then if the patient is stable, we see him every year. And of course, these patients are very aware about all the symptoms that are that can suggest us the onset of another acute episode, so that in case of any of these symptoms, the patient can call us and they will come to perform a test. And these patients are also seen at our center all the times that they need to do an invasive procedure, such as surgery, or in case of a desired pregnancy.
3 more questions left from the audience. One is related to the reticulocyte count. Do you see patients with high creatinine who have very low reticulocyte count?
The answer is no, because the acute kidney failure usually is an acute kidney failure, because these are young patients. Usually they don't have comorbidities, they don't have usually kidney diseases. So if you develop an acute kidney failure, you still have a bone marrow that is able to respond to the acute reduction of hemoglobin. So we don't see, we always see a very high reticulocyte response in these patients.
Thank you. Dr. Visakha has a question about LDH. If all other parameters have settled and LDH remains persistently high, how do you react?
Yeah, LDH is considered by guidelines one of the parameter that is used to define the response to therapy, together with the clinical signs and together with the platelet count. So the LDH doesn't need necessarily to come back to normal values, but should at least be not higher than 1.5 more the higher the upper limit of normal. So if you are in this range, you can consider that you have a response. If the LDH is still high and it doesn't permit you to consider the patient in response, but all the other signs, laboratory signs, the ADAMS 13 levels, the antibodies are in the normal range and would allow you to define the response, I think that you should consider other causes that could be concomitant for an elevation of LDH.
Thank you. And the last question is from Dr. Raghuvendra. Is there a role of romiplastim?
I think that there is no role for romiplastim. I understand the question because you are facing patients with a low platelet count, but it's like the same question as should I transfuse platelets? The response is the answer is no, because you would you have to face the fact that with romiplastim or other TPO-RA, you would not have the response in a quick, in a fast way. So you will have the response maybe after 10-15 days. So you don't really need it in the acute phase. But first of all, remember that we don't want the platelet to become higher in the acute phase, because otherwise these platelets will go to burden more the thrombi that are in the small vessels.
Thank you. From the faculty present here, any question?
Yes, so hello.
Yeah, Bipin, go ahead.
Yeah, so Dr. Marco, my second question and the last question to you is in situation of COVID-19 and reduction of ADMTS 13. So do you think it is it is because of the inactivation caused by the viral infection itself, or is it the overconsumption of ADMTS13 because of the ultra-large multimers?
If Professor Agarwal have heard the question, because I really cannot hear you well. It's really
yeah. So the question, can you hear me now?
Yeah, a little bit better, thanks.
Yeah. So the question is, in situation of COVID-19 and reduction of ADMTS13, do you think it is the inactivation caused by the viral infection, or is it the overconsumption caused by the ultra-large von Willebrand factor?
Okay, I think I've got it now. I think that in COVID-19 is just an infection, so is a trigger as all other infections for TTP onset. The problem is that COVID-19 is an infection that, as we all know, is associated with a very important systemic inflammatory response. And this inflammatory response is responsible for the activation of the endothelium, as all the other infections. And an activated endothelium expresses many different proteins, many different markers, and especially tissue factor, that is the trigger of the extrinsic pathway of the coagulation pathway. And we have to consider also that some reports have showed how SARS-CoV-2 can infect directly the endothelial cells, so that it can act in two different ways: directly by infecting the cells and promoting the expression of procoagulant phenotype for the endothelial cells, and indirectly by the systemic inflammation that it causes. So I think that all what happens in TTP, triggered in this case by SARS-CoV-2, is start in the endothelium of the small vessels. So for sure, endothelial cells that are activated in a prothrombotic way are more prone to start the TTP cascade.
Thank you.
Thank you. So we come to an end to this fantastic session. What a great lecture, and even more stimulating, wonderful discussion based on all these questions. The questions were great, answers were greater. I'm indeed extremely grateful, Dr. Marco, to spare your 2 hours, 2.5 hours being with us this morning, educating all the people from India, this part of the subcontinent, and even around. We have a huge number of people who are logged in from this country, surrounding countries, and even from Europe and US have been listening to you. Half of them are students, postgraduates, fellows, and trainees. They must have benefited in a big way. And even clinicians who have been treating, their knowledge has been updated, and the care of TTP in this part of the world will be much, much better from tomorrow. Grateful to you for this. I also thank everybody involved in this webinar, from Dr. Bhave to all our discussants, to our supporter, Natco Oncology, and the management done by Mice Ideas. Once again, thank you, Dr. Marco Capicio, for sparing your time and being with us. We enjoyed it, and I'm sure everybody enjoyed it. Thank you.
Thank you, Professor, for this kind invitation. It's been a pleasure to be here.
Bye-bye. Bye. Bye to everybody. Bye.
Thank you. Bye.